Good evening on this somewhat rainy, cool evening. I understand it's going to be back up near 90 on Friday. Welcome to the second session of the early fall 2025 mini medical school. We're delighted to have Bay Health as our sponsor for this series. You can follow us on social media. Here are the various tags. And importantly, DelawareMinimed.org is where you go to actually find the videos and the presentations posted usually 24 hours or so after the night of the presentation itself. Here's the YouTube streaming that I was just referring to. I think we covered this last week, but I'll say it one more time. The Academy was founded in 1930. One of its programs is Delaware Health Force, of which I am the director. And one of Delaware Health Force's programs is Delaware Mini Medical School. We're funded currently through the Academy and with American Rescue Act dollars. That's the COVID recovery dollars. We partner with Sussex County Health Coalition, and you'll hear from them in a minute. And as I mentioned, Bay Health. You can attend as many of the sessions as you want to. However, if you want to get a signed certificate of attendance, which is sent to you electronically only, we're not mailing them out hard copy anymore, then you need to either attend all 6 sessions live, or if you miss one, you're going to email Nicole Sabine. I will drop her name and email into the chat. You email her, let her know you missed one, and then she'll hook you up with the process. There's no continuing medical education, no continuing education credit for this. This is strictly for your own edification. There are no grades or tests, but if you miss a session, you will have to answer a couple of questions about the video that you watched after the fact. So why do we do this? We want to enhance health literacy in the community. We want to expose middle, junior, high school, undergrad, graduate students, adult learners who are looking potentially at a career change about a variety of health topics and career choices. This is an opportunity for the presenters to talk with you about their own career pathway and then touch on some good clinical stuff, which you'll definitely be getting today. And it's an opportunity at the end of the presentation for you to post questions in the Q&A. Christy or I will read them to the presenter, and they will then answer the questions. Just remember, nothing of a personal or family nature. I think I covered all of that. You do need to stay through the entire presentation. You can leave when the Q&A starts. And at this point, I am going to turn it over to my friend and colleague, Christy Handley with the Sussex County Health Coalition. Christy, over to you.
Great, thanks, Tim. Sussex County Health Coalition is a proud sponsor and partner with Tim and his group. We are so excited to do these mini med series with him and his team. A little bit about Sussex County Health Coalition. We make sure we're an organization that lives in Sussex County. We do assist individuals in Kent and Sussex County. And what we do is we make sure that we are engaging all of our communities in a collaborative, family-focused manner. So in other words, what we're doing is we're making sure that we're raising awareness out in our communities of some of the health issues and concerns that might be going on in the communities. We make sure that all of our community partners and all of our community members have a voice for any of their concerns and ideas that they may have. And we make sure that those concerns and ideas get to the proper individuals that can listen and maybe help us make some changes within those communities. We also make sure that we're engaging others from all over both counties, and we do include Newcastle County in any community health promotions. We are one of the developers of the very first community health worker apprenticeship program in the state of Delaware. We are leading a community health worker initiative for Kent and Sussex County. So we are mobilizing some of those individuals from our community health worker trainings out into our communities to make sure that they are provided with the effective resources to make sure they're living a better quality of life. We also are building capacity for some of those policy and program development changes and ideas that need to be sent out forward. and we are supporting any collaborative efforts to improve those communities. Thus, our involvement with Tim and his shop for the mini med sessions. That's us. So today I have the honor of introducing Dr. Satyan. I hope I said that correctly. She is a board-certified physician specializing in nephrology. She earned her medical degree from JN Medical College in India, completed her internal medicine and chief residency at William Beaumont Hospital, Royal Oak, Michigan, and completed her nephrology fellowship at Indiana University in Indianapolis. She's been practicing in Kent County, Delaware since 2007 and is a partner of Nephrology Associates. She's on the medical staff at Bay Health Hospital at the Kent campus, and she is the medical director of Dover Home Dialysis Center. In addition to providing direct patient care, Dr. Satyan plays an active role in teaching medical students and residents. She is the clerkship director for nephrology for undergraduate medical graduation and the specialty education coordinator for nephrology for graduate medical education for internal and family medicine residency programs at Bay Health. She has faculty appointments at Philadelphia College of Osteopathic Medicine and at Drexel University College of Medicine. And I would like to welcome Dr. Satyan, and I'm going to turn it over to you for a wonderful presentation.
Thank you so much. Thank you for the kind introduction. I'm going to share my screen.
Something's happening. That's good.
Can you see?
It's starting. It hasn't come up on our side yet. Perhaps stop share and try the cycle again if you would. And as everyone in the class is used to, sometimes technology just does not cooperate. Again, it started screen sharing, but we're still not seeing anything yet.
It says your screen sharing is paused.
Screen sharing is paused. Well, okay. Hold on, everybody. We will figure this out. Do you have the ability on your end do you have an unpause on screen sharing? This is a problem we have not encountered before.
For some reason.
Hey, I think I see something this time. There you go. And now go into slideshow and go into presentation mode. Perfect.
Can you hear me okay?
Yes, we can. Thank you.
Thank you very much. Hello, everybody. Thank you for being here. So we'll be talking about kidneys and kidney diseases today. As the title slide refers, it's all about the beans referring to kidneys. So a brief outline, we'll be talking about the kidney structure, kidney function, and kidney diseases. The terms kidney, renal, and nephro basically are used interchangeably for anything related to kidney. So what are kidneys? As you can see here, kidneys are bean-shaped organs measuring about the size of a fist, located in the back on either side of the spine, right below the rib cage. And you can see two kidneys, one on each side. And they play an essential role of removing wastes and toxins. They regulate fluid, electrolyte, and acid-base balance. They regulate blood pressure, and they produce hormones that assist with red blood cell production and keep bones strong. So this picture shows you the outline of the anatomy of the kidney. So most of us will have two kidneys unless somebody is born with one kidney or something else happens. And you can see right and left kidney, and you can see the blood vessels going to the and from the kidney. And you can see the tubes from the kidney going down to the bladder. And to the right, it just shows you what the kidney does. You get blood from the large blood vessel called the aorta. The cleaning process takes place in the kidney, and the clean blood is returned back from the renal vein. And then the waste products are removed through this tube called the ureter, and then goes into the bladder from where it's excreted. So this is the structure of the kidney. So if you take a vertical section of the kidney, this is what it would look like. The outer part, there's a protective layer called the renal capsule, and the outer part of the kidney is called the cortex, and the inner part of the kidney is called the medulla. So most of the filtration I'll talk about in a bit, it happens in this cortex area. And then once the urine is formed, it collects into this region called the renal pelvis, and then out it goes down the ureter, and you can see the blood vessels, the renal artery, and the renal vein. So what is a nephron? Nephron is basically a functional microscopic unit of the kidney. So on average, there's about 1 million nephrons in each kidney. We're born with a set number of nephrons. So once you're born, there's no change. Once it's damaged, it cannot be regenerated. So whatever you're born with, that's all you have, and about 1 million nephrons on each side. So it comprises of these tiny blood vessels that you see in red called the glomerulus. And then there is a complex tubular system. You can see the one that comes from the glomerulus is called the proximal tubule. And then this is called the loop of Henle. And then there is a distal convoluted tubule and the collecting duct. So the glomerulus, together with this complex tubular system, decides what stays in the body and what gets excreted in the urine. So I'll show you in a little bit in detail about how this works, but the human body has the amazing ability to determine what you need and what needs to be excreted. So most of the substances that you need will be held back by the kidney, and only the waste product goes. And likewise, the nephrons have the amazing ability to concentrate the urine or dilute as needed. So depending on the body's needs, you'll make less urine or more urine because of the work that is done by the nephron. So that's basically the functional part of the kidney. So this is just a joke. Why did the kidney go to school? To learn how to concentrate. So how do kidneys actually work? You can see this large artery called the aorta. From there, there is a blood vessel that goes to the kidney called the renal artery. So the blood flows from the renal artery and passes through these filtering units called the glomeruli. And the glomeruli, along with the tubules, can tell the difference between what the body needs and what you do not. And so they filter out the waste and extra fluid from the blood to make the urine. And this urine is carried to the bladder through these tubes called the ureter. And then urine is removed when people urinate. So the cleaned and filtered blood is returned back into the body through this vein called the renal vein, and then goes into the inferior vena cava. So this process is taking place continuously, 24/7. So this is a brief video about how kidneys work.
Just below your rib cage, behind your belly, sit two bean-shaped organs that act as your body's cleaning and organization team. They're your kidneys, and they're responsible for taking stock of your body's inventory. They keep what you need, toss out the rest, and even replenish the pantry when you're running low. And while you may give your house a good spring cleaning once a year, if even, your kidneys work around the clock to clear out the clutter. They filter through all your blood about every hour, day in and day out. So how do kidneys work? Let's take a closer look. Throughout the course of the day, a lot of stuff moves through your body. The nutrients from the food you eat, as well as certain byproducts made when you exercise, digest food, and more. It all winds up in your blood. And that blood flows into your kidneys through your renal artery. Once there, your kidneys comb through your blood and decide what stays and what goes. It's a two-step process. First, your blood flows through blood vessels called glomeruli. They act as a pasta strainer, holding on to what they need and letting the rest go to waste. Then it moves on to your renal tubules. They're more like a mesh strainer, more precise in choosing what to keep. The tubules fine-tune your blood to keep the things you need, like vitamins, minerals, sodium, and potassium. And they send the good stuff back out to cycle through your body. The tubules also weed out the stuff you don't need. Too much acid? See ya! Extra protein? Get out of here. Excess fluid? Bye-bye. Your kidneys send all those extras to your bladder, and they leave your body as pee. But the work doesn't stop there. As they sort through your blood, your kidneys also take stock of what's missing. When you need some sugar, your kidneys make glucose. If your blood pressure is low, your kidneys produce a hormone called renin to bring it back up. If you need more red blood cells, your kidneys help make more by releasing a hormone called erythropoietin. Your kidneys also make the hormone cortisol, which helps your body respond to stress. It also helps regulate your metabolism, reduce inflammation, regulate your blood pressure, and improve your sugar levels. Your kidneys do a lot for you, so take good care of them. Drink plenty of water, exercise daily, maintain a healthy weight, and avoid excess salt. If a clean home is a happy home, a clean body is a healthy body. And it all starts with your kidneys.
So hopefully that was a good overview about how the kidneys work. So now moving on to kidney diseases. There are several types of kidney diseases. We're not going to be able to go into the details of everything, but some of the diseases are listed here. Acute kidney injury, we'll talk about it in a second. Electrolyte and acid-base disorders. Chronic kidney disease, again, the term acute and chronic depend on the duration. The glomerular disorders, if anything happens to the glomerulus. The tubulointerstitial disorders. Vascular diseases, diseases of the blood vessels of the kidney. And there are some hereditary kidney diseases. and then kidney stones and infections. And we'll go through some of them today. So this is a microscopic appearance. I showed you the gross section, what a kidney would look like. So if you put a needle in and take a small piece of kidney tissue and look at it under the microscope, this is what it would look like. As I mentioned before, this is the main filtration unit. It's called the glomerulus. And then the tubules are all right here around the glomerulus. And the space in between the tubules is called the interstitium. You don't see the blood vessels here. So the disease of the kidney usually involves one or more of these parts of the kidney. So what is acute kidney injury? So whenever there is a sudden loss of kidney function, usually happens within 48 hours, but can be up to 7 days. Some of the causes are listed here, most commonly as a result of low blood pressure for whatever reason, infections, dehydration, medications, muscle injury, any reason why there is blockage of urine flow, such as stones or tumors, certain other disease conditions like liver disease, heart failure, autoimmune disorders, all can cause acute kidney injury. People who have major surgeries are also at risk for acute kidney injury, and there are a few other causes as well. So the diagnosis is based on symptoms and signs, and it could be very non-specific, people just feeling tired and weak, to something very serious like confusion and seizures, or worsening swelling in the legs, etc. We usually do blood test called serum creatinine to tell if there is any damage to the kidney, and urine tests, as well as imaging like ultrasound, CT scan. Sometimes we may have to do a kidney biopsy to find out exactly what the cause of kidney injury, acute kidney injury is. And the treatment really depends on what the underlying cause is, and that needs to be treated. Sometimes it improves and goes back to normal function, but if it is prolonged, the risk is that it could be irreversible, or sometimes in between the spectrum. So fluid and electrolyte management, blood pressure management is important. And depending on the cause, certain medications are used to treat acute kidney injury. And if all else fails, we do a procedure called dialysis, which actually acts as a supportive mechanism to remove the excess toxins and fluid that build up as a result of kidney failure. So most important is prevention. Again, avoiding low blood pressure, avoiding dehydration, avoiding infections, avoiding medications that are not good for the kidneys, etc. Electrolyte disorders. So electrolytes basically balance body fluids. They regulate heart rhythm, and they support nerve, muscle, and bone function. And you can see the electrolytes listed here. You might have heard of sodium, potassium, magnesium, calcium, and phosphorus. So reduced kidney function can impair body's ability to regulate the electrolyte levels. Normally, these electrolytes are managed, fine-tuned in a very tight range. So when the electrolyte levels become too high or too low, it could be problematic. For example, patients with kidney failure are at risk for very high potassium levels, and that can cause arrhythmias. People who drink too much water while doing a marathon, for example, can drop their sodium too low, and that can cause seizures. So should just be aware of the various electrolytes that are regulated and the problems that can occur as a result of the levels being too high or too low. Acid-base disorders. So the normal blood pH, just like how the electrolytes are tightly regulated, the normal blood pH is very important It's between 7.35 and 7.45, and it is very tightly regulated, and it's very important for the function of the various cells. If it is too low, it's a condition called acidosis, and if it's too high, it's a condition called alkalosis. And this figure here shows what the pH is in the various parts of the body. But normal healthy kidneys will maintain the acid-base balance and keep the blood pH in the normal range. So metabolic acidosis and metabolic alkalosis occur when kidneys are unable to maintain the balance, and that can cause problems within the body when it does happen. Glomerular disorders. Again, like I mentioned before, glomerulus is the tiny looping blood vessels that act as filtering units. And as you can see here, this is a normal glomerular filtration system. And when the glomerulus is diseased, it's called glomerulonephritis or nephrotic syndrome. Itis is generally used in the medical field to refer to inflammation. So as a result, blood and protein that should normally not leak into the urine will leak into the urine as a result of the disease. Some of the symptoms could be foamy appearance of the urine just because of the presence of the protein in the urine. Blood in the urine could appear as a pink or cola-colored urine. Swelling in the face and in the legs, and often associated with high blood pressure. So you could do blood tests, you could do urine tests, ultimately kidney biopsy. And the treatment depends on the type and cause. There are several types of glomerular disorders, common ones being from lupus, also known as SLE, IgA nephropathy, infections from hepatitis B and C, and several other causes of glomerular disorders. I told a kidney joke, but it got no reaction. Guess it didn't filter through. This is another joke from the internet. So there are some hereditary diseases, kidney diseases, that are passed on in the family. The most common one being the polycystic kidney disease. And you can see here what a normal kidney looks like and the diseased polycystic kidney disease. So in this condition, the entire kidney gets eventually replaced with all of these cysts, and they could become pretty large in size. Alport syndrome is another hereditary kidney disease, typically associated with a family history of blood in the urine and some hearing loss. Fabry disease is another hereditary kidney disease as well. Kidney stones. So the hard deposits of minerals and salts that form inside the kidney form the kidney stones. They're very common. Types are calcium oxalate and calcium phosphate. So the calcium-based stones are the most common. Uric acid stones can be associated with conditions like gout. Struvite stones are large, also known as staghorn calculi, that can be associated with infections, and another genetic cause called the cystine stones. So the risk factors for stone formation, usually it's because of less water, high salt or animal protein diet, certain medical conditions and certain medications, as well as family history. And the symptoms, usually people develop flank pain or back pain, blood in the urine, nausea and vomiting sometimes, or difficulty or frequent urination. So the small stones have the ability to pass on their own. So you just advise people to drink plenty of water, give them pain medication if the pain is severe. But the larger stones require surgery, like the shockwave lithotripsy. Sometimes the urologist will put a scope in and try to remove the stones, or sometimes open surgery, depending on the type and location of the stone and complications. So prevention is very important, staying well hydrated, avoiding high salt diet, etc., and maintaining a healthy lifestyle. What is chronic kidney disease? So I talked about acute kidney injury where it occurs within 48 hours or up to 7 days. So chronic kidney disease basically is a condition associated with the gradual loss of kidney function, and that occurs over 3 months or longer. And these are some of the statistics from May 2024 from the Centers for Disease Control. More than 1 in 7 US adults may have chronic kidney disease at any given time, but most importantly, most of them don't know they have it. So you have to do tests to find out if somebody has chronic kidney disease. And they are one of the leading causes of death in the United States. That's why it's important to screen and treat early on. And about 360 people begin treatment for kidney failure, either with dialysis or kidney transplant every single day. And there are some tests to detect the chronic kidney disease, a blood test known as serum creatinine, and you can estimate what is known as GFR, also known as glomerular filtration rate. Urine test, looking for blood or protein or white cells. Urine ACR, it measures albumin excretion. And sometimes we have to do kidney ultrasound or CT scan or MRI. And if we don't know the cause, we do a kidney biopsy to find out what exactly the cause is so it can be treated. So this graph about GFR shows what is the normal range. So the normal GFR is about 120. Usually, kidney disease is characterized when it goes below 60. And if it goes below 15, it's considered kidney failure. And you can also see to the right the test for urine protein, also known as albumin. So normally, healthy kidneys, you don't leak protein into the urine, whereas a damaged kidney, the protein leaves the blood and enters the urine. So these are the two important tests that tell you if somebody has chronic kidney disease. So I'll let you watch a video about chronic kidney disease.
Most people have two kidneys, about the size of their fist, located in their lower back. Just like your brain or heart, kidneys keep you alive. Many people know their cholesterol and blood pressure numbers, but they also need to know their kidney numbers to see if their kidneys are healthy or if they have chronic kidney disease, also called CKD. Having CKD means that you've had a kidney problem for at least 3 months. Chronic kidney disease can creep up on you slowly and silently. You can be losing kidney function for many years without symptoms. Many people find out that they have CKD only when their kidneys have failed and it's too late for preventive treatment. At this point, they usually need dialysis or a kidney transplant. That's why knowing your kidney numbers is so important. There are two kidney numbers: estimated glomerular filtration rate, eGFR, measured by a blood test, and urine albumin to creatinine ratio, UACR, measured by a urine test. The eGFR shows how well your kidneys clean your blood, and the UACR shows if there's a protein called albumin in your urine, which may mean that your kidneys are damaged. Along with your kidney numbers, your doctor reviews your health history and performs other tests. This complete evaluation helps to confirm or rule out if you have chronic kidney disease. The kidney numbers and different colors create the CKD heat map, which shows you the possible risk of your CKD getting worse and your risk for heart disease. The good news is that when it's found early and treated right, the outlook for kidney disease patients can be very bright.
All right, so what are some of the risk factors for chronic kidney disease? Diabetes, high blood pressure are two of the most important risk factors for chronic kidney disease. Heart disease, obesity, family history of chronic kidney disease, as well as older age are additional risk factors. And it's important to treat chronic kidney disease to lower the risk for what is known as end-stage kidney disease or kidney failure. In addition, chronic kidney disease also increases the risk for heart disease and heart failure, stroke, and early death. So that's why it's important to screen people at higher risk for chronic kidney disease and to start treatment early. So this was basically the CKD heat map that you saw in the video, and this is based on the GFR to the left and the albumin excretion to the right. And you can see that the green bars represent low risk, yellow bars represent moderate risk, the orange bars represent high risk, and the red bars represent very high risk. So when people develop chronic kidney disease, the doctor will usually, in addition to looking at the cause of chronic kidney disease, will look at their GFR and the albumin excretion to determine what the risk category is for a patient, and then advise the patient about what treatments to implement. So what are some of the treatment options for chronic kidney disease? Again, it depends on the treatment of the underlying cause. Most of the times it's high blood pressure and diabetes. So good blood pressure control with a target of less than 130 over 80 millimeters of mercury is very important. We use a class of medications called ACE inhibitors or ARBs, you might have heard. But mostly, many of these patients will require 2 or 3, sometimes 4 or more medications to get the blood pressure under control. Blood glucose control is also very important in diabetics with a target hemoglobin A1C is the test that is used to assess blood glucose control in diabetics. So we target less than 7%. Cholesterol control with the use of this medication class called statins is important. And some of the other medications that have been approved for chronic kidney disease include a class of medication called SGLT2 inhibitors, GLP-1 receptor agonists, and non-steroidal mineralocorticoid receptor antagonists. Lifestyle modification is very important, such as smoking cessation, proper diet, exercise, coping with stress, good sleep hygiene, maintaining healthy body weight, etc. Avoiding certain type of medications. For example, non-steroidal anti-inflammatory medications are considered nephrotoxic. And then treating the associated CKD complications, such as anemia as a result of low red blood cell production, or bone disease as a result of less vitamin D. And there are several other additional treatments in the pipeline, hopefully will be available for routine use in the next few years. So what are some of the symptoms of chronic kidney disease? I mentioned early on that most people with chronic kidney disease don't know they have it until it's detected by a blood or a urine test. But these are some of the symptoms. You can see this picture from Cleveland Clinic, but they usually don't occur until it's advanced stage, usually less than GFR of 30, sometimes even lower. But it could be just dry and itchy skin, tiredness or weakness. People who have a lot of protein in the urine will have a foamy appearance to it, swelling of the hands, feet, puffy eyes, ankles, trouble sleeping, poor appetite, muscle cramps or restless legs, and difficulty with urination or going to urinate more frequently or decreased urinal. So kidney failure or end-stage kidney disease basically refers to the last stage of CKD because of irreversible loss of kidney function. So we call that kidney failure when the kidneys are no longer able to do the function, and you need some kind of what we call kidney replacement treatments to sustain life. And it can be in the form of dialysis, and I'll show you some videos pertaining to that, hemodialysis that can be done in a center or at home, peritoneal dialysis. Or a better option is to get a kidney transplant, either from a living donor, like a friend or a family member, or a deceased donor. You have to be listed to get a deceased donor kidney. It's important to note that people can live with one kidney. So both if you're a recipient of a kidney transplant or if you're a donor donating a kidney, um, you can live with one kidney, provided that there is nothing else going on in the body. For people who are not candidates for either dialysis or kidney transplant, or some patients may choose to forego either of these treatments and they just choose conservative management with medications and palliative care options. And there are some future experimental treatments in the pipeline. You might have seen some on the news. One is called a xenotransplantation. Because there is shortage of kidney transplants with a long wait time in this country, genetically modified pig kidneys are being studied for transplantation. And they're also looking at a more portable way of kidney support, such as artificial or wearable kidneys that mimics the normal healthy kidney physiology as close as possible compared to the current dialysis treatments. So I'll let you watch a couple of few more videos. It talks about, this is all from the National Kidney Foundation. The first one talks about hemodialysis, and you'll hear some real patients talking about their experience doing these dialysis treatments.
Welcome to Live Well with Kidney Failure, brought to you by the National Kidney Foundation. In this video, you'll learn about hemodialysis, a treatment for kidney failure.
Doctor,
We'll
we
discuss
seem to
what
have
it is,
gone back
how it is
to
done,
seeing
and we'll
you
present some
and not the share screen.
Oh, you can't see the screen?
No, we're seeing just you.
Okay. When did you last see me? I
Oh,
mean,
it
hear
just
the
started.
slide.
Just when you went to share the video clip. Oh, never mind.
It
You know
says,
what? No, you're fine. Go ahead and hit play. My bad.
The advantages and disadvantages of this type of treatment.
There are two ways to treat kidney failure: dialysis and kidney transplant. To learn about a kidney transplant or peritoneal dialysis, which is another type of dialysis, watch the videos on those subjects. So, what is hemodialysis? It is a treatment that removes waste products and extra fluid from your blood, and it's often called HD, or hemo for short.
During hemodialysis, your blood is pumped through soft tubes to a dialysis machine. Inside the machine, there's a special filter called a dialyzer, or artificial kidney. The artificial kidney allows waste and extra fluid to pass through while holding back important things, like blood cells and nutrients. As your blood is filtered, it is returned to your bloodstream. Only a small amount of blood, about a half a cup, is out of your body at any time. The whole process takes 3 to 5 hours. Most people need treatment at least 3 times a week.
You will need to have an access, or entrance, to your bloodstream. This is done with minor surgery, usually to your arm. You will also have 2 needles inserted temporarily during each hemodialysis treatment to get blood into the hemodialysis machine.
Hemodialysis can be done at home or in a dialysis center. To do hemodialysis at home, you'll need to set up your home for the machine and other equipment. You'll also need a care partner to help you and room for supplies. This is usually a family member or friend, but may also be someone you hire to assist you. You and your care partner will receive special training on how to do your treatment safely. If you do hemodialysis at home, a dialysis center will arrange for the equipment and supplies. They will follow your treatments closely and see you when you come in for your checkups. You'll also be given a 24-hour telephone number in case of emergencies. There are many advantages to doing hemodialysis at home. Some people feel it gives them more flexibility and that they're better able to fit it into their daily schedule. Or they might prefer being at home with family during treatments or not having to travel back and forth to a treatment center. In other words, some people feel it gives them a greater sense of control and independence. But there are other things to consider too. You must have a care partner to help you and enough space in your home for a machine, water, and supplies. And you'll need to take charge of the machine itself, prepping it beforehand, cleaning it, storing it. And you'll need to monitor your own vitals during treatment.
I'm a mother, I'm a wife. I teach Sunday school for almost 30 years now. When they told me I had to go on dialysis, I was introduced to the home hemodialysis. I wasn't prepared for how I was going to feel. I trained at the center that taught us every aspect of the machine, what it does. Once I did that, I was confident. I don't think you could do it alone, so having a support team is really important. I asked 2 of my friends to help me, plus my husband does it on the weekends with me. So I feel like I have a nice team that works with me. You could mess up unless you know what you're doing, but once you get in the swing of it, it gets easier and easier to do. Sometimes I get scared thinking I got to do this until, when, how long, forever maybe. But then I go back to that simple plan, a day at a time. And that's what gets me through. I started working from home. I'm delighted with that because I get to see my daughter during the day. I get to work in a nice atmosphere. The quality of life is really wonderful. Dialysis is amazing because it functions as a body part, outside of your body. And without that machine, I wouldn't be able to live. That's what it comes down to. There's things that you do have to work with, you have to give up, but what's, the price? It's easy to give them up when you know that you're getting your life back. The inspiration I would give to someone else is don't give up. If you go to the classes and you think they're a little tough, everything gets easier. I have to say that I've learned to love it. I feel like I have a better lifestyle. No one would ever think I was sick if I didn't see my arm. I'm not really sick. I think of myself as a well person. If you put your mindset in the right place, you can do absolutely anything. I really believe that.
The other choice is to do hemodialysis in a dialysis center. In a dialysis center, the staff takes care of the dialysis machine and monitors you throughout your treatment. Some people like the social aspect of being around other people who are getting treatment at the same time. But there are some drawbacks too. Treatment hours are scheduled by the center and may not fit your personal needs. You'll also need to travel to the dialysis center 3 times a week for a treatment that lasts about 3 to 4 hours each time. Whatever your choice, at home or in a dialysis center, you will be working with a trained dialysis staff member to make sure you're receiving the right amount of hemodialysis. Blood tests will be done regularly to check on the amount of dialysis you receive and to help decide if any adjustments to your treatment are needed.
I was born in Trinidad and Tobago. Before my kidneys failed, I used to surf a lot and I loved to dance, and I used to run track for my school too. When I was around 16, I remember one day I was making hot dogs in the kitchen and I was picking up, my hand was shaking. My mother was like, "Byron, you know your hand is shaking." I went and they took blood, and 2 days later, results came. The doctor said that your son's blood is so toxic that it could kill a horse. I started treatment right away. I've been receiving dialysis for over 26 years. I don't cut my treatment, 3 times a week for 26 years, and sometimes I don't want to go. And having a good technician next to you when you stay, he will know when I'm having a bad day. I walk in, he could tell. And I could walk and I could tell he's having a bad day. So it's like, I respect him, respects me, and that goes a long way. That's why staff is so important to have that. I have a very good relationship with my treatment team, especially with the administrator. If I have a problem, she's very proactive. When you go to a good treatment center and you have good nurses, you have good doctors, you have good technicians, and you take care of that and you go home. And yeah, you can get good home treatment, but for me personally, I want to leave that aside and I don't really want to come home to it. It's tough, but sometimes that's the only time that you have peace of mind. No one's bothering you. I got my days, man. I got my days. It's tough. For me, keeping positive is ready to fight. I love a challenge. If I know there's somewhere I can fight for, I love that. That's why I try to keep positive,
Hemodialysis does a good job in filtering out waste products and extra fluid, but it can't completely take over the work of healthy kidneys. For these other jobs, you'll need to take different medicines and control the foods you eat and the amount of fluids you drink. A dietitian can work with you to create a meal plan that takes into account your general health, any medicines you take, and what you and your family like to eat. You may need to take medicine to control your blood pressure, help keep your bones strong, and help your body make red blood cells. Taking all your medicines as instructed is very important.
If you choose hemodialysis, you can still be evaluated for a transplant or peritoneal dialysis later on. Many people experience different treatments for their kidney failure throughout their life. As your needs change over time, so can your treatment. Before we close, let's do a quick review. Hemodialysis uses a machine and an artificial kidney to remove waste products and extra fluids from the blood. It is usually done at least 3 times a week for several hours. You will need a special access that must be surgically placed in your arm to allow your blood to flow out to the dialysis machine and back during treatment. Hemodialysis can be done at a dialysis center or at home. Whether you do hemodialysis at home or in a center, you will have a dedicated healthcare team working with you and your family to give you the best care possible.
Please read the companion booklet to this video. You can also learn more about hemodialysis by asking your healthcare team or contacting the National Kidney Foundation at 1-855-NKF-CARES or www.kidney.org.
All right, the next video is about peritoneal dialysis. So as they described in the video, the entire healthcare team, the physician, along with the dietitian, social worker, nurse, works with the patient to determine what is the best choice for them, and then we'll plan the treatment accordingly. So this is a second type of dialysis called peritoneal dialysis, and you'll hear a little bit more about what the process is and from
Welcome
patients'
to Live Well with Kidney Failure, brought to you by the National Kidney Foundation. In this video, you'll learn about peritoneal dialysis, a treatment for kidney failure. To learn about a kidney transplant or hemodialysis, which is the other type of dialysis, watch the other videos in this series.
So what is peritoneal dialysis? It is a treatment that removes waste products and extra fluid from your blood, and it is often called PD for short. In PD, your blood is cleaned from inside your body, not outside. Many people consider this an advantage over hemodialysis. PD is done every day, 7 days a week, and you do it yourself. The fact that it's done daily is an advantage because salt, water, and waste products never build up in your body.
To do PD, you'll need a soft tube called a catheter placed in your belly. This is done by minor surgery. There are 2 main types of PD. The first type is called CAPD, which stands for Continuous Ambulatory Peritoneal Dialysis. In this type, you will connect the catheter to a special tube that allows 2 to 3 quarts of a cleansing fluid to flow into your belly. The cleansing fluid is called dialysate. It takes about 10 minutes for the cleansing fluid to fill your belly. Once that's done, the catheter is capped so that it doesn't leak. What happens next is an amazing process. The lining of your belly acts as a natural filter. It lets the waste products and extra fluid in your blood pass through it into the cleansing fluid. At the same time, the lining of your belly holds back the important things your body needs, like red blood cells and nutrients. The cleansing fluid must stay in your belly for several hours, depending on your body size and how much waste has to be removed. This time is called your dwell time. Afterwards, you drain the cleansing fluid from your body into an empty bag and then throw it out. You repeat the in and out process usually 3 to 4 times per day using fresh cleansing fluid. This process is called exchanges. Because it cleans your blood while it's inside the body, it can be done anywhere and anytime, at home, at work, or while traveling.
The other main type of PD is called APD, or automated peritoneal dialysis. In this type, a machine called a cycler does the exchanges for you while you sleep. In APD, you'll connect your catheter to the cycler at night before you go to sleep. You will not be doing the exchanges yourself during the day. Instead, the cycler will do the bag exchanges for you, automatically filling your belly with fresh solution and automatically draining it out. The cycler is a mechanical way of doing the exchanges for you while you sleep. Except for this, CAPD and APD are the same process. The type of PD you choose will depend on your lifestyle and your preference. You may start with one type of PD and switch to another, or you may find that a combination suits you best.
Let's pause for a quick recap about the 2 different types. In one type of PD, you do the exchanges yourself, usually 3 to 4 times a day. No machine is used. In the other type, a machine called a cycler does the exchanges for you while you sleep. In both types, blood never leaves your body, and you'll need a catheter permanently placed inside your belly.
PD has many advantages. It can be scheduled around work, school, travel, and other activities. It can also be a good choice for someone who lives far from a clinic or has no reliable transportation to a dialysis center. One drawback is the risk of getting an infection called peritonitis. Peritonitis is treatable, and it's important to get it treated promptly. Carefully following your nurse's instructions and training can help you reduce this risk.
My name is Margaret, but people usually call me Meg. I'm a retired school teacher. Before I was diagnosed, I felt crummy all the time. I had this doctor come into the hospital room when I was there, and he's like, "You need to start coming to see me because you have kidney issues." And I'm like, "Oh no, not me, you know." When I went to the dialysis center just for an overview of what they do, one of the nurses, as I was leaving, she said to me, "This is really knocking you for a loop, isn't it?" And when she said that, it was like I just crumbled, you know. It's like, yes, I don't want to have kidney failure, and, you know, I don't want to have this to happen to me. I talked with the peritoneal people. For my case, I was still working, so doing it at home while I sleep seemed like the perfect way for me. I told my husband, he was like, "Well, you're going to have to do that for the rest of your life." I'm like, "Yeah, I am." I have to have a rest of my life. You just hook it up to your own port, press the go button, and you're set for the next 8 hours and 12 minutes. I sleep. I don't even know it's happening. It's great. And since I've started, I feel so much better. I have more energy. I go to the playground with my niece and play when she's here, and I make sure I get out usually every day, do something. There's nothing I can't do anymore. That sounds strange, but I feel so much better since I've started the treatment that I don't consider myself sick.
If you choose PD, you'll be taught everything you need to know, including how to do the exchanges, order supplies, clean your catheter, and protect against infection. You'll continue to meet monthly with your healthcare team for checkups. They'll monitor your medicines, diet, and overall health. They'll also check your lab results to make sure enough waste products and fluids are being removed by your treatments. PD does a good job in removing waste products and extra fluid from your blood, but it can't completely take over the work healthy kidneys do. These other jobs are done through the different medicines you'll need to take and by controlling the foods you eat and the amount of fluid you drink. A dietitian can work with you to create a meal plan that takes into account your general health, any medicines you take, and what you and your family like to eat. You may need to take medicine to control blood pressure, help keep bones strong, and help your body make red blood cells. Taking all your medicines as instructed is very important.
If you choose PD, you can still be evaluated for a transplant or hemodialysis later on. Many people experience different treatments for kidney failure throughout their life. As your needs change over time, so can your treatment.
Let's review. With PD, your blood never leaves your body since the dialysis process is done inside your own belly. PD is done every day, 7 days a week, and it needs a catheter to be permanently placed inside your belly. In one type of PD, you do the exchanges yourself, usually 3 to 4 times a day. No machine is used. In the other type, a machine called a cycler does the exchanges for you while you sleep. Many people feel that PD gives them a greater sense of control and independence because they can schedule it around work, school, travel, and things they like to do.
Please read the companion booklet to this video. You can also learn more about peritoneal dialysis by asking your healthcare team or contacting the National Kidney Foundation at 1-855-NKF-CARES or www.kidney.org.
So hopefully that was a good overview of the 2 types of dialysis, the hemodialysis and the peritoneal dialysis, and the options that patients have. But the main choice for kidney failure is kidney transplantation. So this just shows, it's an animation of how the transplant procedure is done.
In a kidney transplant, a healthy kidney from a donor replaces the function of the recipient's non-working kidneys. This is achieved through surgery, where the donor kidney is implanted in the lower abdomen. The kidney is connected to the recipient's blood supply by attaching it to an artery and a vein that previously served one of the failing kidneys. Additionally, the ureter, a tube that transports urine from the kidney to the bladder, is also connected to ensure proper urinary function. In most cases, the damaged kidneys are not removed unless they are causing complications.
So dialysis is a treatment for kidney failure that is essentially used as a bridge to kidney transplant. So ultimate goal is to get a kidney transplant. But for some reason, if somebody is not a candidate for kidney transplant, or if people don't want a kidney transplant, then they might just choose to stay on dialysis.
In a kidney.
So to summarize, kidneys are important organs in the body performing numerous essential functions. And there are several types of kidney diseases depending on the part of the kidney that is involved. And it can be acute or chronic depending on the duration. Early detection and treatment through blood and urine tests and other tests is necessary to start treatment and delay progression. Kidney replacement treatments, as you saw, for appropriate patients can be life-saving. Even if somebody goes into kidney failure, there is options. Conservative or palliative care options for some patients who are either not candidates for dialysis or transplant, or if they choose not to go through those treatments. Most importantly, prevention is the most important thing, especially for the high-risk group. Avoiding nephrotoxic medications, etc., plays a big role in preventing the onset of kidney disease, as well as treating the risk factors early on to prevent the onset of kidney disease. So community awareness and education are essential for prevention and early detection. So hopefully you learned something about kidney and kidney disease today. With this, I will stop and we'll be happy to take any questions.
All right, thank you very much. And questions we do have. And just a reminder to everybody, we don't use the raised hand. So this is the time to place your questions into the Q&A. And this goes back first to the beginning of your presentation. Could you explain how FSGS works I've heard it mentioned before, and I'm curious as to how it works.
Yeah, so FSGS refers to a type of disease affecting the glomerulus. It stands for focal segmental glomerulosclerosis. So when I talked about the different types of glomerular disorders causing blood and protein leaking into the urine, one of the conditions is called FSGS. So the glomerulus, which is the filtrating unit, is not able to prevent its disease, so it leaks protein into the urine, and as a result, people develop swelling in the legs and develop a condition called nephrotic syndrome. Depending on the cause, there are various treatments available. It can be as a result of systemic diseases like high blood pressure or obesity, or it can be primary FSGS, where there is development of glomerular disease on its own without a secondary problem. So the treatment depends really on what the type of FSGS is, and you diagnose it with the kidney biopsy.
All righty. Next interesting question. What factors determine how many kidneys you are born with?
So almost everybody will be born with 2 kidneys. And there are some things that happen in utero that might result in just 1 kidney, or the other kidney does not develop. So those are usually developmental factors. But for the most part, everybody is born with kidneys. Some people may not even know that they have 1 kidney, or the other kidney is not well developed unless you do like an imaging to figure it out.
Put myself on mute. What do you think about the future experimental wearable kidney?
So that is a good option. It is exciting. It's not available for mainstream yet. And again, the goal is with either type of dialysis, even though there are significant advancements made to improve the quality of life for people doing dialysis, these wearable kidneys kind of mimic the physiology of the kidney. So if you think about it, the kidneys are working constantly 24/7. Even the best of dialysis treatments only offers like a fraction of the filtration and the cleaning process that is needed. So this is meant to provide a better quality of life in terms of being able to wear and be more mobile, as so to speak, and also to mimic the physiology of the kidney that works 24/7. So there are several universities across the United States that are doing experiments on various types. So they have to pass through several stages of clinical trial and be successful before they can be mainstream, but hopefully in the near future.
All righty. And perhaps, or perhaps not a related question, if an elderly woman was diagnosed with something such as prolapse, does the kidney have any effect on that suspected diagnosis?
So there are different types of prolapse. There is uterine prolapse. There is like bladder prolapse. The kidneys are usually only affected if there is some type of like a compression or external compression causing obstruction to the flow of the urine. But otherwise, they will be treated by urologists or gynecologists, depending on the type of prolapse. So as long as there is no blockage to the flow of urine and they don't have any other reason to develop kidney disease, it shouldn't.
All righty. You were talking about genetically passed diseases, and one of them was Allport's. Is that passed transmitted from one parent or the other? And would an all-ports patient benefit from dialysis?
Yes, we do have Alport's patients on dialysis. Again, when it is diagnosed, it can be diagnosed with genetic testing. Usually it is suspected if you have somebody with unexplained protein in the urine, especially with a family history or blood in the urine. So the genetic testing will help confirm. And what was the second question? Will they benefit from dialysis? So if it progresses to the point of kidney failure, needing dialysis, yes, they will benefit from dialysis or kidney transplant if they can get one.
All righty. Next question I'm going to expand upon just a little bit. So the Gift of Life donor program is the expansion. How does a kidney transplant from a deceased person work? And of course, first we need to talk about deceased. Over to you.
I'm not sure I understood the question. How does a deceased donor transplant work?
Yes, correct.
Okay, so deceased donor transplant is basically from a deceased donor, meaning if somebody died and they had listed themselves as donor, and so there is a donor, there is a team that inspects all the organs depending on what the preference of the person who died or the family is. And then if they feel that it is suitable for kidneys, so there is what is called United Network Organ Sharing for kidney transplants. And there are several kidney transplant centers throughout the country. In Delaware, Christiana does kidney transplants. So each kidney transplant center will have patients with kidney failure listed as potential transplant candidates. So if they are active on the list, depending on where they are in the list, people at the top of the list will get preference. And there are several networks. So there is Delaware, Pennsylvania network. So depending on the availability of the deceased donor kidney, then the transplant team will reach out to the recipient on top of the list and see if they are a match. Again, they have to look into several criteria to see if the kidneys can be transplanted. First of all, make sure that the person receiving the kidney is healthy. The donor kidney is good enough to be transplanted. And then they have to do certain matches called the HLA matches, certainly the blood type match. And then if they're candidates, they will call the patient who's on the list and say, there is a kidney available. Are you willing to come? And then once they go there, they will be able to undergo the surgery.
Alrighty. How do you feel about electrolyte supplements such as licensed medical nutrition therapy?
So the electrolyte supplements, you have to be careful. It depends on what type of electrolytes you need and why you need. So it really depends on the individual needs. So I listed those common electrolytes like sodium, potassium, magnesium, etc. But you have to do the blood test and the doctor has to determine if you need any supplements. So for example, people with very low potassium or very low magnesium or very low calcium or phosphorus levels, first of all, you have to figure out why you're low in those electrolytes. And then if you need supplementation, and the doctor will make the determination. So the needs vary depending on what the cause of the electrolyte disorder is. And a doctor will be able to do a good history and physical and do blood tests and determine if they need supplementation.
Okay. And a perfect follow-up to that. Can you just ask your doctor for a kidney test, or does there need to be a reason of some kind that your practitioner determines you need to have a kidney test done?
Yeah, so many patients who see doctors for healthcare, if they get a routine blood test and a urine test, that will give you the information about the serum creatinine that I mentioned and the eGFR, and then the urine test will look for blood and protein. But if they want to specifically look for the urine albumin excretion, for example, they would have to order a specific test. So for usually during routine physicals, physicians might do blood and urine tests, and that might determine whether or not somebody has kidney disease. But certain high-risk individuals, like people with diabetes and high blood pressure or family history, you would have to ask specifically to do the screening tests for kidney disease.
Okay. Are there differences in how kidney diseases present between men and women?
To a certain extent, yes, but the fundamental principle is the same. Like I showed the kidney anatomy and the pathology of the various types of kidney. Certain types of kidney disorders might be more common in one gender versus the other, but the principle is the same. But some of the differences might be related to anatomy. For example, when I talked about acute kidney injury from obstruction causing blockage to urine flow, men might be more predisposed, especially older men, because of prostate enlargement causing blockage to the urine flow. So, so those types of things vary between men and women, but the general principle, whether it's acute kidney injury or the glomerular disorders, or the chronic kidney disease and the risk factors kind of stay the same.
All righty. During dialysis, do the chemicals used affect any of the other organs? And she follows up by saying, thank you so much for an amazing presentation.
Well, you're welcome. I hope it was useful. So the chemicals, in the sense that, so the dialysis, the dialysate is basically a ultra pure water. So depending on the type of dialysis, the hemodialysis or the peritoneal dialysis, the dialysis solution is called the dialysate, which is basically an ultra pure water. If you get a chance to go to a dialysis center, you will see how the city water goes through multiple water purification tests, and they're all examined to make sure they're completely pure. And then the only chemicals that are added are basically the electrolytes and the bicarbonate. And that is it. So there is no extra chemical that is added to the dialysis solution. The only chemicals that are used are basically to clean the equipment. So technically, the answer is no, but it's basically the ultra pure water with the electrolytes and the bicarbonate to balance everything out. That's what you're exposed to. Now, I will say that when people do hemodialysis, you use a kind of like an artificial kidney, the filter called the dialyzer. Sometimes people may develop allergic reaction to it. It's rare because those are basically the membranes that kind of do the filtration process like the normal kidney does in hemodialysis. So, but there are other types of dialyzers that you could use if somebody were to develop an allergic reaction.
All right. If you're using either hemodialysis or peritoneal dialysis, do you still produce urine? If so, will it be dilute or concentrated urine?
Great question. Very great questions. I'm really impressed with the audience today and the questions. So when people go on dialysis, the hemodialysis or peritoneal dialysis, typically their kidney function is less than 15%. And sometimes we may wait until it's less than 10%, as long as the patients are doing okay. So even if they start when their kidney function, the GFR is around 8, so there is still a little bit of kidney function left. So they will make urine. So it is not well concentrated. But over time with dialysis, each individual behaves differently, but people lose that, what we call the residual kidney function. So the urine output might decrease. It usually decreases faster when they go to a center for hemodialysis compared to peritoneal dialysis. So that is one of the advantages if somebody is a candidate for peritoneal dialysis, to maintain that residual kidney function. But in both types of dialysis, ultimately, people may stop making urine. Some may produce urine longer than others. It also depends on everything else that's going on in the body. I hope that answers the question.
All righty, we've got so many questions here that I'm chiming in here and answering some of the easier ones. How long does the access in the arm last?
That's another great question. So when they do hemodialysis, they have to have what is known as access in the arm. It's basically a connection between the artery and the vein. And the goal is to develop the walls of the vein because they're usually thin walled and the arteries are thick walled. So the connection needs to happen because you're putting two needles, one on the arterial side and the other on the venous side, one to draw the blood that goes through the dialyzer, and then the clean blood returns back into the body through the vein. So the ideal type of access is called fistula. So we usually refer patients who we think might need hemodialysis soon to be evaluated by a surgeon. They will look at their vein measurements and determine if they can get a fistula. Fistula, you're not putting any artificial material. The surgeons will basically make a connection between the artery and the vein. For some reason, if the blood vessels are not good enough to do the fistula, then the surgeons might elect to do a procedure called the AV graft, arteriovenous graft, which is an artificial material between the artery and the vein. So depending on whether it's a fistula or a graft, fistula usually lasts much longer. Sometimes it needs additional procedures. So patients who are on dialysis will get tests to see the flow on the fistula and do additional procedures to improve the longevity. But it can last several years. We've had patients with AV fistula lasting 10, 15 years. If it clots off and if it cannot be opened, then they would need to have a new procedure. But generally, AV fistulas are the best form of AV access and last much longer than the grafts.
Righty. Well, let's go back up to the top here. Christy, I'm taking all the fun. I'm sorry. There was a question. Okay. If you have kidney failure or disease, could you just get that kidney removed, or do you need a full transplant? So remove one kidney, remove both kidneys, transplant, so on.
Great question. So the kidneys are only removed if they're causing problems, meaning somebody has cancer of the kidney, then the kidney gets removed. The medical kidney diseases that I'm talking about, like chronic kidney disease that eventually goes into kidney failure, usually as a result of a systemic condition, whether it's diabetes or high blood pressure or heart disease or some type of glomerulonephritis, it affects both kidneys. So in that case, the kidneys are not removed. When they get a kidney transplant, those what we call native kidneys just stay there. They're probably shrunk. They're not working at all. But a new kidney is placed in the lower part of the abdomen called the iliac fossa. The reason to remove a kidney usually is because of a tumor. If a tumor you're not sure if it's cancerous or you know it's cancerous, then they remove the kidney. If they can't just remove a portion of the kidney, they'll remove the whole kidney. Some other reasons to remove the kidney is if it's causing problems like frequent infections, etc., or stones. So those are rare reasons, but most of the time kidney is removed because of concern for tumor or cancer. But if it is just medical kidney disease, you don't remove them.
Okay, I'm going to ask that the questions now stop. We've got way more than we can have our presenter answer. Let's talk a little bit about your educational pathway. You're relatively unique for one of our presenters, in that your schooling was originally done in another country. But tell us about that, and how did you select this particular specialty and so on?
Yeah. So, yeah, I went to medical school when I was in India. So in India, you don't do undergraduation. Right after high school, 12th grade, you kind of make the decision whether or not you want to go into medical school. And that's when I made the decision to go to medical school. It's a 5.5 year training where it's 4.5 years of all the classes. Initially starts in the classroom and the lab, and then you go to the hospitals for your clinical experience. And then the last 1 year is what we call internship. So we rotate through different departments of medical offices, surgeries, orthopedic surgery, OBGYN, etc. And those are all required, and 3 months of underserved areas to complete the graduation process. So once that's done, most people will go into a further training. It's very rare for somebody to just graduate from medical school and start a practice. So then they will decide what type of specialty they want to go into, if it's surgery or internal medicine or family medicine or gynecology or psychiatry, etc. So I came to the United States a couple of years after my medical school was completed. I graduated from medical school in India, and then I came to the United States. And I had to go through some licensing exams because I was a student of a foreign a medical school. There's something called ECFMG certification. So you go through the licensing exams that both the American graduates and the foreign medical graduates have to do. It's called the USMLE Step 1 and Step 2. We also had a specific clinical skills exam. So you pass all of that, and then you apply for residency. During my medical school and internship, I kind of knew that I wanted to go into the medicine field and not so much the surgical field. So internal medicine kind of comprises, basically it's an umbrella of all organ and subspecialties. So that's the path I chose. And after going through, a lot of interview process, then I landed in Royal Oak, Michigan, where I did my residency and an extra year as a chief resident. But my passion for kidneys started way earlier. Right when I went to medical school, my father was diagnosed with kidney disease. And simultaneously, I was learning about kidney physiology in medical school. So I was very fascinated by how all these nephrons work. I consider kidneys to be the brainiest organs in the body, just because of their ability to fine tune everything every second, every minute of the day. So that fascinated me. And then after seeing my father go through several stages of kidney disease, dialysis, and then kidney transplant, I kind of wanted to make a commitment to take care of patients with kidney disease, because I knew what my family went through. And so that gave me the perspective of what family goes through when they develop kidney disease. And then when I was doing my residency training in internal medicine, I did the rotations in nephrology, both in the inpatient hospital setting and in the outpatient setting. And that kind of further solidified. So I applied for a nephrology fellowship, and then went to Indiana University, and it was a 2-year training. I completed that, and then joined this practice called Nephrology Associates in Delaware right after I finished trainings in 2007. And I've been here since. So hopefully that answers the question.
All righty, last question from Aratrika. As a college student working on engineering organoids, I was wondering, what are your opinions on the future of tissue engineered kidney transplants, kidney regeneration?
Yeah, I mean, that's an amazing field. So hopefully you'll be able to teach us a little bit more. The xenotransplantation is kind of being looked at now, which is basically the genetically modified pig kidneys, just to increase the availability of transplants, just because human kidneys, there is a huge shortage. In terms of bioengineered kidneys, I mean, we have a long way to go. I think there are some in the experimental stages where, we talked about the artificial kidneys where they're aligned with the kidney tubule cells. So it's not all artificial means to make it more like the regular body kidney to do it. So that's like an exciting field. But if you have any other information to share about anything that is going on, I'd be happy to listen.
All righty. Well, Doctor, thank you very much. That was almost a record number of questions asked in a very short period of time. A reminder to everyone who stayed on, which is a large number, we are not meeting next week. We start again on October the 1st with palliative care, making people feel better even when we can't fix them. Great seeing you all. Doctor, thank you again. See you in a couple of weeks. Good night.
Thank you, Tim. Thank you, everybody.